Hello, everyone. I'm going to describe to you how to present a patient in the newborn nursery. It's pretty straightforward, and I like to um, basically just describe things in a sequential manner. I think it's easier to learn that way, and I think it'll be very helpful for like third-year medical students, fourth-year medical students, and even medical interns in their first-year residency. So, here we go. So the first thing you want to do, obviously, is your HPI. First thing you want is to ID the patient, right? So that just means their gender, right? Hours of age, and then their name, if they have one. Sometimes parents haven't decided a name, and that's okay. Um, and then the second thing you want to do is talk about their gestational age. And then the third thing you want to do is talk about how they were born. So I'll just call it method of delivery. Um, and then after that, you want to talk about basically IDing the mother. So this is what I mean by that. So when you ID the mother, you're basically talking about how old she is when she gave birth to the baby, and then her G's and P's. This is something that you'll probably come into more experience with during your OB rotation. But G's and P's basically are a designation that we, as practitioners, know how many times was mom pregnant, and then how many times did she actually give birth. And then the P's break down into further sections about how many term babies does she have, how many preterm babies does she have, how many are alive, or sorry, excuse me, how many are aborted, and then how many are living. But for right now, we'll just keep it to how many births and how many are alive right now. So, and this is really your first sentence, right, when you're presenting the patient. So you would say, this is a male 40 weeker at 24 hours old. His name is, I don't know, Kyle or something. He's a 37 or 40 weeker born vaginally to a 24-year-old G2 P2. That's kind of how you would say it. So that's usually like your first sentence. It's your introductory to presenting a patient. It should always be like the first things you say. And then after that, you would get into more details about mom's prenatal labs, anything that's important, right? So when you're talking about mom's prenatal labs, these can have a big effect on how you take care of baby for the next couple days while they're in the nursery. So that would mean like, okay, what was mom's blood type, right? What was her antibody screen? Her Hep B status, right? A lot of times you get like a syphilis screen as well, gonorrhea, chlamydia, right? HIV test, and even a PPD. If it was positive, then probably a chest X-ray too, right? So the prenatal labs. So once you get at about step 5 here, you're already starting out wide and then bringing it into more of a, you can start to tell where the story is going, right? So as far as like, again, the first 4 things, these things already kind of lead you into things you might need to take care of when you're talking about baby. So if baby is less than 37 weeks gestational age, there are certain outcomes and differences in care for a kid that age. So if baby's preterm, then there are certain things we need to check that you'll talk about in your assessment and plan. If a baby's 39 weeks, 40 weeks, there are other things you have to check as part of the care for baby, right? So as you go down, like I said, you start to get a story, and you can kind of tell where it's leading. So as far as mom's blood type, you start getting into this, especially when you're talking about like ABO incompatibility, RH incompatibility, Hep B status. If mom was Hep B positive without a vaccine, then your management of baby changes drastically. Same with syphilis, same with gonorrhea, same with HIV, obviously, same with TB. So right around here, once you get to 5, people's ears perk up if anything's other than what they would expect, especially with these prenatal labs. With incompatibility, that's a common thing, especially if one of the parents is Rh negative. So it's things like that that doesn't get people's ears to perk up. But once you get to if one of these are positive, then you've got something going on, right? So the next thing after you've gotten through that part is any pregnancy complications. And how they were treated, right? And this you can usually find in the OB's note on like the computer chart. So these are things like gestational diabetes, gestational hypertension, anything that could affect the pregnancy, or anything that did affect the pregnancy, rather, can change how you take care of baby. So these are things you want to talk about if they existed at all. Like, I remember I had a patient with like hyperthyroidism, or Graves' disease, maternal Graves' disease. That changed how we had to handle baby's care in the next couple days. So yeah, you can usually find that in the OB's note. And the next thing you should talk about is the rupture of membranes, right? And specifically, how long was it? And the fluid color. Now, if rupture of membranes is too long, and I think it's 18 hours, it's called prolonged rupture of membranes, right? And that's a risk of infection for baby, right? So baby's exposed to the open air. Baby could get some kind of bacteria through the birth canal, monopoly group B strep, things like that. So the pediatrician, the attending, is going to want to know how long was baby ruptured, or how long was the membrane ruptured, right? And then fluid color. This is especially important because, again, it's another thing that could lead to infection. So best case scenario, fluid's clear, right? But what if there's blood, right? Did mom abrupt? Is baby gonna be anemic because of loss of blood? Is the fluid meconium stain brown, right? Is this a risk of infection for baby? Is that something we're gonna have to watch more closely as baby goes through his first couple days, right? And then the next thing you want to talk about is if there were any delivery complications. Now, again, and then also obviously what was done, right? So a common delivery complication that you'll see is shoulder dystocia. And so for that, it's like, what did OB do? Or arrest of, what's it called? What's it called? Like delayed descent, right? Did the OB have to use a vacuum to get baby out? That changes your management of baby too. If baby has a vacuum delivery, and then somehow gets bruising on the top of the baby's head, then would that lead to higher bilirubin counts because of the bruising? Those things are things you have to consider. And so you definitely want to talk about if there was any complications with delivery, especially like things like shoulder dystocia, because now we're thinking, okay, is baby's collarbone broken from the delivery because it was difficult to give birth to? So those are things that, again, you need to talk about when you're presenting your patient, right? And this is something you can find in the delivery note. This is also written by the OB. And then for the rupture of membranes, you can find that in the OB's H&P as well. So this is in the OB's note. So 6 and 7 you can find in the OB's H&P generally. Or no, sorry, 6 you can find in the H&P generally. 7 and 8 you can usually find in like the delivery note written by the OB. And so after you've gone through, if there were any delivery complications, then you start talking about, okay, what was the APGAR score? Now, APGAR is an acronym. It's basically used to describe what is baby's health condition within the first 1 in 5 minutes of life. This is also something you'll see on your PED shelf too. And then if with resuscitation measures, right? If baby's APGAR scores were low, what was done about it, right? And so at this point, you can kind of tell that you're building a story, a timeline, straight from identifying who these people are, right? Mom and baby, and how old baby is, all the way to prenatal things that may or may not have happened throughout the pregnancy, and then rupture of membranes to the delivery, and then now baby's out at part 9. What was baby's health status? What did the baby look like? Was he breathing? Was the pulse above 100 or not? Things like that. And then what was done about it? Did they just have to suction baby? Did they have to intubate baby? There could be all kinds of things that they might have had to do depending on the APGAR score. So you always want to talk about APGARs, especially when you're going through an initial presentation of a newborn infant to your attending. And then once you've got the APGAR score, okay, so you've established that baby's out, baby's healthy for the first 5-10 minutes, right? Now you need to give a quick blurb about like, what is baby's status, clinical status, right, since birth. And by that I mean, is the baby well, sick, not sick, things like that. Also, you want to talk about, how's mom feeding baby? Is baby pooping and peeing? Are the vitals stable? And what's the baby's weight? Right? So you want to talk about this, and I mean by clinical status since birth, because you want to know, okay, is baby doing well on his own? Is mom breastfeeding baby? Is baby bottle fed? This is especially important in stooling and voiding, because this is one of the barriers to discharge. So if baby hasn't pooped yet or hasn't peed yet, can't go home. So we need to know about that, right? The vitals. Newborn vitals are very finicky, right? If baby gets cold, that's a scary sign. And so hopefully it's nothing. Maybe the baby just wasn't bundled well enough, or baby just needs like the radiant warmer. But hypothermia is also one of those things we talk about with newborn sepsis, things like that. And then baby's weight. Is baby losing weight, which we'd expect, right, to a degree? Or is baby gaining weight? Something. Make sure you mention at least what the birth weight is. So when we're looking on the computer and talking about the baby, we know if baby's doing well, right? So at first we expect baby to lose about 7% of the birth weight. But if baby's lost 10%, let's say, of birth weight, then we start getting worried. Is baby getting fed enough? So once you get through all of that, you start talking about, okay, is there family history that we need to worry about? And particularly, what, like the newborn, what about the baby's siblings as a newborn? Was there something that happened to the siblings that we need to look for in the baby? Um, and this is obviously something that the parents are going to know best, right? What about, any congenital diseases that the siblings may have, or, oh, excuse my spelling, it's terrible. Congenital diseases, right? So, is there something mom might have had as a baby, like a ventricular septal defect, perhaps, or some kind of hereditary cardiac condition that may be passed down? Anything like that? Were there any childhood deaths, unexplained, right? Things like that you want to ask, right? And then if they're not there, just say there was no particular family history with cardiac conditions or congenital disorders, or the baby's older siblings have all been healthy since birth, things like that. And then once you get through that, you want to talk about, social history. And then really in particular, you're just talking about, the family status. What is the family dynamic like? And really, you're really just narrowing, is mom and dad together? Um, Things like that. Where is baby going to live? Who is living with the baby? Who else is living with the baby? And then if the parents have already picked one, you want to talk about the primary care provider. Who is this baby going to see for the well child checks, right? And then after that, you want to talk about, okay, what's the physical exam? And really, you're just trying to narrow down pertinent findings. Now, by this point, you have started off broad, and then by about the middle way here, you've started to narrow down what's really important about this kid, right? So let's say our baby has a mother who was positive for HIV, right? By here, but once you mention that at this point, a lot of this should be about what are the things that we would expect to have with an HIV baby. Were those things there or not? And you need to make like special attention to mentioning whether those things were there, right? So an example of that was by the time you get down to, I don't know, mode of feeding, let's say, right? If mom was HIV positive and her HIV RNA levels were high enough that they had the C-section baby, right? I would hope you'd mention right here, you mention how baby's being fed, because that's really important. If mom had to give a C-section because her RNA for HIV were too high, baby has to get bottle fed, right? It can't be breastfed. So that's why you mention these kind of things, because it all should add up, right? And then on physical exam, you're just mentioning like, how is baby doing? Things like that. Just, you start your physical exam from head to toe, and mention any findings that seem off to you, right? And then once you get through your physical exam, you basically want to talk about your assessment and plan. Now, some people smush these two together. I'm one of those people. It's totally fine. And really, to give an assessment, you get a difficult explanation how to do that from, like, I'm sure teachers in your past in medical school, because it's really a nebulous term about how to give a good assessment. And then I'll make another video just to it'll be a really short video, but it'll be easy to explain. But basically, you want to answer a few questions, right? So here you again basically go through part 1, right? Just basically identifying the baby, right? So you do part 1. Then you talk about why is baby here, which is pretty easy. This is the easy part. Just birth hospitalization, right? And then you do, okay, is there any treatments that need to be done because of anything that you talked about up here, right? So an example again for a HIV baby, if mom's RNA was super high, right, we'd have to start baby on Ziduvudine, right? Um, so like any treatments, basically. Right? That's kind of the quick baseline assessment, but I'll explain a little more about assessments later. And probably another video. It'll be easier that way. But so you go through your assessment, right, and then your plan. So there's really like two ways to do a plan. Some people do it problem based. Some people do it system based. Where I trained, it was system based. And so for newborns, a healthy newborn, there are really four systems that you always talk about, right? Whether or not you have to do anything. So the first is like, okay, you know, FENGI, right? Fluids, electrolytes, and nutrition, and gastrointestinal. And this is always about like, you know, how is baby being fed, right? What are we doing about fluids? Is baby eating enough, right? All the things that would go into that would go into FNGI, right? The second thing is always infectious disease, right? Again, going back to the HIV kid, we need to be talking about what we're doing about the fact that baby may be HIV positive right now. And then the third thing would be like the respiratory status, right? Newborns are notorious for having respiratory issues. Transient tachypnea of the newborn, right? Respiratory distress syndrome of the newborn. Persistent pulmonary hypertension of the newborn. All these things will need to be addressed in this part. If they are there, right? If nothing's happening, then it's pretty easy plan to lay out, right? And then the fourth system is hematology. And this is where you get into the ABO incompatibility, the RH incompatibility, if there are any like genetic hematologic disorders like sickle cell or thalassemia, things like that. Those parts are addressed here. But those are the base four that generally are talked about every time when you're given a plan. That's pretty much it, though. I hope this helped.